So in response to the question, is CD47 a good target for lymphomas? I think the answer is yes. I think it is, though I think we have a lot to learn. You know, when we look at T-cell checkpoint inhibitors, for instance, in lymphomas, we've had very much a mixed bag, remarkably effective and importantly effective in things like Hodgkin lymphoma, sort of variable or less effective in other forms of B-cell lymphoma, relatively ineffective in multiple myeloma, if we include that in lymphomas. And then the area I most focus on, T-cell lymphomas, it's really been, you know, very good and very bad, meaning we have some relapse refractory diseases like NK T-cell lymphoma, where the early reports are that T-cell checkpoint inhibitors can be quite effective, resulting in complete response rates, sometimes durable complete response rate, maybe as high as 50% of the time. But then we have issues like in adult T-cell leukemia lymphoma, or ATL, where there's been significant hyperprogression, even leading to some patient deaths. And the data in sort of the more common types of T-cell lymphoma has been very mixed. There's a few responders, but there are also reports of hyperprogression or high rates of early progression, which may either be inactivity or hyperprogression in the more common types of T-cell lymphoma, both with inhibitors of PD-1 and PD-L1. So I think there's certainly an unmet need in lymphomas for additional immunotherapeutic options. And I think that's where CD47 strategies could really fill a unique space. So CD47, of course, is what's called the don't eat me signal that's expressed on many cancer cells, including lymphoid malignancies. You know, again, in my field, we see it frequently on Sézary syndrome, cutaneous T-cell lymphomas, and then on some other T-cell lymphomas. And we think the expression of that molecule really blocks phagocytosis by macrophages or other immune cells. And the idea is that if you interrupt that interaction, you probably need an additional eat me signal or additional stimulation that you can sort of unshield those cells from the immune system. And in early studies of some of the 47 antibodies like HU5F9, we've seen relative safety, lower levels of activity, and then in SIRP alpha decoy receptor, TTI-621, which has an interruption of the don't eat me signal, but also gives an IgG1 eat me signal, we've seen independent single agent activity. So I think there's a role certainly for these drugs to be explored. I think in terms of safety, they really fit in line with what we've seen with other commonly used therapies. With some of the anti-CD47 strategies, one of the main side effects is anemia. CD47 is of course expressed on older red blood cells, and we do see some early breakdown of those cells and some anemia. And that's been addressed in various priming strategies where it looks like you can give the drug safely without cumulative side effects. In the SIRP alpha decoy receptor, we've seen a little more thrombocytopenia, but again, like with the anemia, it tends to be a first dose and a fairly transient phenomena, and something that's certainly, when you're looking for it, not out of the safety range of many other drugs we use. So I think the proof of principle is there. I think the early data of responses and safety is there. And then it's really just a question of sort of the heavy lifting of clinical research to figure out where they work, where they don't work, how best to use them. And I think those studies are going on looking broadly. And then it probably, where they're going to find their best use is with some additional antibodies. So of course, the excellent results of HU5F9 combined with rituximab to give a localizing antibody stimulate an eat me signal in addition to blocking CD47. And those results published by Dr. Advani in the New England Journal of Medicine really set a proof of principle that by adding an antibody or an eat me signal to the don't eat me signal, you can really overcome other resistance and get meaningful responses in that case in B-cell lymphomas. I think in T-cell lymphomas, we're sort of thinking along the same lines. Do we need to give other additional molecules? How much of this is a single agent activity? And then after sort of interruption of the 47 pathway, getting phagocytosis, how reliably does that lead to activation of the innate immune system, getting T-cell activation? As that may be one of the ways that we'll really get a broader activity and more durable responses. So again, in answer to the question, is it a good target? I think it is, and I think we're early on in the understanding, but I see a lot of ways that this will go forward, at least in clinical research, and hopefully translate into useful clinical use as we learn more.